Our next conversation is one that I know is on top of everybody's mind. The topic's come up a couple of times over the last couple of days during day 1 and day 2. And so, what is that? It is around artificial intelligence. So, our next panel will be discussing, the title is Cutting Edge Innovations in AI. Again, if you're online, make sure you're jumping to the next session to join us and be able to see the whole thing. It's my pleasure to introduce our moderator today, Holly Longstaff. Holly is the Director of Research Integration and Innovation at PHSA and is an adjunct professor at the Faculty of Health Sciences at Simon Fraser University. Welcome, Holly. Our panelists are here in person already, one joining us virtually. Let's give them a round of applause.
Hello, for people who don't know me, I'm an ethicist. So I support researchers across the province that are associated with the Provincial Health Services Authority. I know many of these people already, and you're very fortunate. We're having an incredible discussion in the back room. I told them to stop talking so that they wouldn't lose their energy when they come out here. I just want to remind us of what our goals and learning objectives are for this particular session. It's to explore the current applications of AI in the BC health system, discuss the future vision, and considering the associated risks and opportunities. So we have our panelists, Andre, Elizabeth, Michael, and Lyndia behind us there virtually. I'm going to ask them to go one by one and just introduce themselves very briefly, talk about their affiliations and how they use AI in their work. And we'll start with Andre.
Okay, can you hear me? Yep. Yeah, my name's Andre Kushniruk. If you don't know me, I'm the director of the School of Health Information Science at UVic. I know many graduates here, and I've been doing that since about 2004. So in terms of AI work, I just mentioned I have a couple of examples of current ones and then back up and say how I even got into the relation with AI. Actually, one of my examples was already previously discussed. It was the dermatology application with Providence Health. We had a supercluster project. Elizabeth was on it about 3 years ago with a company, MetaUp and Providence Health. And it really worked well. It was an AI application that allowed in the GP's office to take a picture, images were brought down, and then if it looked like it could be a problem, sending referral to a dermatologist. And then the evaluation we did, it had reduced the wait time from, I think it was 192 days who most of the referrals were under 5 days in the project. So that was something, and I never knew what happened with that project. So it was very heartening to hear that that's actually being used. That's a bit of a theme of my thing. And the other project where I'm doing other research, we're doing one with ChatGPT, where the patients can tell whether it's from ChatGPT or another physician for information. But my background, it was kind of a long and circuitous path with AI, which covers what I'm doing now. Back in the mid 1980s, I had just graduated with a master's in computers, and we could get AI jobs. It was another heyday of AI. I worked for Imperial Hydro on nuclear, alarm filtering. I worked with CP Rail, of all things, and kind of bumbled my way to a lab at University of Toronto at the end of the 80s, AI lab. And at that time, different ideas were coming out. And I remember a fellow came from England, Jeffrey Hinton, who was working on artificial neural nets. And at the time, I thought, well, that would never end up being used very widely. And it ended up 40 years later with computing power expanding. But for me, I was doing what was called rule-based AI. And it was something we called then the AI winter. You couldn't get funding all the time for AI up until about 1990. And then I changed fields, and I thought the problem with AI was human factors. How do you integrate AI into healthcare? Trust issues, liability issues. What happens if there's an error, failure mode? That's a human factors term. And no one was really looking at that. So I switched to human factors and then got into healthcare. And am coming back at the AI after many years, looking at it from a human factors lens, and just finished doing a piece that was our old issues were current. So the technology is obviously much more sophisticated. It's changed, but we're arguing for more rigorous testing and actual methods, not just saying AI needs to be safer, but how can you do that? And the panelists will talk about that. And revisiting it all now in light of many years later. So that's just the come along secure this journey on the AI, and why I'm interested in specifically the human factors aspects of AI. Some of those problems are still there. Yeah.
It's great. Thank you. And Elizabeth?
Hi, my name is Elizabeth Borycki, and I'm a professor at the School of Health Information Science. Last couple of years, I've been doing quite a bit of research in and around technology safety. I come at technology safety from a learning health systems approach, in that we launch technologies and we might identify safety issues, and we fix them. And over time, we become a safer industry, very similar to the aviation industry, where we started off in cases where there were a lot of crashes involving planes, but today's aviation industry is exceptionally safe and very streamlined, and we get take a lot of people to a lot of good places and bring them home safely. So that's my perspective. In addition to that, we've done a lot of work in the school and with our lab around developing different types of methodologies that can be used to evaluate safety, to understand what kinds of things are happening that may influence safety. We use that as a way of developing out methods and learning, and then introducing them into industry so they can use those methodologies themselves. Had a lot of successes internationally over the last couple of years. From an AI perspective, a lot of the methodologies are applicable. I would encourage you to reach out, look at what's out there, and if you're interested in learning a little bit more about different methods, we're certainly available from that perspective.
And Michael? No. Button thing.
That should work. Okay. So I come from a different background here. So I am the Chief Digital Innovation Officer at PHSA, but it also, we kind of have, I think it's sometimes worthwhile explaining, we have this partnership with PHSA and the Ministry of Health, and we kind of sit in the middle. So I look at it from, how do we deploy these things into the healthcare system? I think I recall very clearly, we started seeing demos, and my boss turned to me and she said, "We need a strategy and a plan." I'm like, "Yep." And so where my team, I have a couple kind of, I would say, pillars within my team. So I have enterprise architecture, which is going to be helping us design that kind of how we're going to integrate and how this stuff is going to fit. I have strategy that's going to work on the plan and how do we, the gotchas, I think. And then we have innovation kind of working with that. And so what we're trying to do is figure out, how do we take this tooling and what we can see in a way that is thoughtful, as I mentioned earlier this morning, for providers and patients. Like, there's a lot of interesting use cases. There really are there. I personally am still feeling concerned. I see Mark there. It's like data. Rarely do we see a change happening within our health system that requires everybody. Like, sometimes, I could feel comfortable going, I know how this works, get the teams doing it, delivered, but we need almost all of us, the whole sector. And I kind of go back, and I know maybe Shannon over there gets confused because I say we need an AI team and we need a provincial group because yes, okay, there you go. The boss says yes. But it is all of that because you have to think of it holistically, like the ethics of how we do it, the importance of how we manage the data. I am concerned, how do we ensure biases don't occur in this data? There's push to, you start seeing it getting into the diagnosing of stuff, and you're like, well, can we trust that we can get past the hallucinations that occur in this data? Can we trust it? So I think what we're doing very much is creating a lot of POCs. We have a lot going forward. Two guys right there you can talk to after did some really interesting POCs for me, and they're really good. They're starting to show stuff. It's just that integration, that final step into delivering healthcare in a trust way is going to be, I think, some of the challenges we need to have.
Thank you. And last but not least, Lyndia behind us. You want to just introduce yourself briefly, your affiliation, and how you use AI in your work?
Yeah. So hello, everyone. And I'm excited to join you virtually today. Hopefully you're not too intimidated by a huge me on the screen here. And so I'm an assistant professor in mechanical engineering at UBC, and so I'm a little bit more on the technology development side of things. And so AI, as we know it, is more talking about the software side of things, but my research interests are are also to develop the hardware that goes with the AI. So a couple of example applications that we work on, for example, we develop wearable sensors for concussion detection. We also develop sensors for sleep monitoring. And so in these cases, we're using AI to try to make decisions such as whether or not we can detect an athlete sustaining an impact on the head, and whether or not we can use that to determine if they have a significant risk of sustaining a concussion. And on the sleep side, we can use wearable sensors to estimate whether or not somebody might be at risk for having a sleep disorder. And so as the consumers are also having more access to these types of technologies that are tracking their step count or tracking their sleep, I think it's very important for us researchers to come in and help interpret the data in a meaningful way and ensure that consumers are not, misguided, because just from our experiences, technology is imperfect, and a lot of times these technologies might be giving very noisy data or algorithms are not fully validated, and so there are some risks here that we need to consider. But very excited to be here with the rest of the panel and looking forward to addressing some questions.
Thank you. So you've met the panel. We have Andre, Elizabeth, Michael, Lyndia. I have lots and lots of questions for them, but if you have questions, please raise your hand. We'll get a mic to you. We also have questions coming in online that you'll bring to me when they come in. But in the meantime, I'm going to start asking these folks questions. So start thinking about yours in your head now. My first question is to Andre. What kind of healthcare applications has AI been the most successful in your view?
Well, I'll just list them and my characterization of them. I mean, we've seen in radiology, pre-processing of X-rays, reports, pathology along those lines has also been something. This morning was dermatology was already mentioned. We can look at other areas. I was looking at successes in the last few years, even automated consultations to some extent with things like psychiatry. Included in AI, I include robotic surgery. There's AI aspects. So many of you know about the Da Vinci robotics system that has revolutionized surgery, and that's an important one. And just information for patients and others. But from many of the ones I've seen, because I also have studied psychology, they often seem to work well in what we call well-defined tasks. For example, a neural net application determining whether that image of the mole is cancerous or not, higher than human accuracy. But there are many areas that are less defined, organizational and other issues. So we're putting together sort of a taxonomy of use cases, or in the human factors term, tasks mapped to types of technology and success in that. So there have been a lot. And coming back to this field many years later, I was really surprised how many applications, but there are many other factors. How we determine success. Is it actually accurate is one way, but does it integrate into your healthcare system is a real success measure. And then you get into barriers like I was at a conference in the US a couple of years ago about how many of these applications are FDA approved. And the managers on the panel from the hospital said, we really like it if they're FDA approved because it reduces our liability. So there's a lot of devil in the detail from, and I count those kind of things as human factors, which is why I'm saying human factors is the key. I believe the technology is there, it's been proven, and there's new areas all the time as it advances.
My next question is for Elizabeth then. What are some AI safety issues that need to be considered during procurement and implementation?
So I actually take the approach that you really need to look at whether or not the AI that you're planning on procuring, whether you have something in the organization that already performs that function first. And then the second part of that is to understand if there's anything else that performs better, because there are things that perform better. So some algorithms perform better than AI in terms of how it's designed. So recognize that it might be as simple as a logistic regression that can be more effective than using some new designed algorithm. and that's published out in the literature. So think of what you're doing and why you're doing it. From a safety perspective, also, it's really important to understand, especially if you're bringing something into your organization, where it's going to fit in the organization, how the health professionals are going to be using it, how will you make them aware of its use, and what its boundaries are in terms of its use. So it's really important to look at where it fits and also potential training strategies and issues. And you can actually do this type of testing. So for example, you could implement and you could and try it out in a local setting to see what potential issues are there.
Okay. All right, next question is for Michael. How do we bridge, what are some of the technical challenges that we have in implementing AI solutions at scale in BC? That's a good question for you.
Yeah, and I have actually a lot of notes, but I'll start with the one that kind of concerns me the most and I'll go to the kind of the ethical framework around how we do this, because I think for us, it's very much that frontline deployment, and it's really the trust of the tooling, of the algorithms that we build, regardless of, I need that framework to feel that I feel comfortable that then we know we're doing the right things, because a lot of the things that are obvious, privacy and security, we have to be transparent on the data that we're training the algorithms in and the models in. We also have to make sure it's secure. The more we're distributing this data around, Italian. The more we distribute these models around, the broader the attack surfaces are, that we need to make sure they're secure. For us, it's also ensuring that we trust the partners that we are. We are not ourselves going to build the scale that we need, so we need to have that as well. Also ensuring there's no biases in the data. If you look at our province, we have very disparate populations across the province, and there's certain populations located in the north versus maybe what we get in the interior. So how, from a province perspective, do we look at it holistically? I get a little nervous sometimes when I hear, well, we're going to do the AI this way over here, and I'm like, well, it's a really small subset of the sector. So what are the implications there? So I think those are some of them, and then transparency on the models and how they're actually producing the answers. So what happens when we get a wrong answer? Are we able to understand what happened and then fix it? And then I think finding the sweet spot for us right now, I think it's really recognizing AI as more of a silent partner, like an assistant, a really smart assistant, versus taking over the role of the human. I think it's all of the use cases that we're looking at in the POCs is looking for ways to optimize the human delivering. And I think that's really where we see the safety net, like of the humans being there. So everything that we've been looking at, we want to see human intervention before anything's actioned with the information that's given.
Great, thank you. And I had a question for Lyndia, but something has come up online for you, Lyndia. So here's a question for you. What is the best wearable AI for sleep tracking you've found and its level of accuracy?
Yeah, that's a very good question. Everybody's so interested in their sleep, and all of us are sleep deprived probably, and we suffer from various types of sleep problems. So I would say that the consumer technologies out there range from something that you can just easily download on your phone as an app that's using the phone's existing hardware sensors to make some detections, to actually separate sensors that you can put onto your wrist, say a wristband or a ring or a headband, etc. And so they range in complexity and simplicity of whether or not you're already able to access it using your phone. So I would say for example, the ones that are implemented through a phone app are just using the phone's internal built-in sensors, such as motion sensors and sound sensors. And so in that case, they really have access to limited information. And it really depends on where you're putting your phone next to your bed overnight, whether or not they might be making an accurate detection of, say, your movements in bed. But a lot of these things do depend on whether or not you're moving in bed to then make a decision of whether or not you're likely to be asleep. And so that also means that it's likely going to have a lot of trouble in cases of, say, insomnia, where you're just lying still in bed trying to sleep, but you're not sleeping, and all the sensor sees is that you're lying still, and it would think, okay, this person is sleeping. And so that's why if we go with these simpler, more accessible technologies, likely the accuracy will suffer because they have limited information available to them. However, as we move up in the ladder of complexity of technology, where if we're actually mounting, say, a cap or a headband to measure brain waves, for example, there's a device, Canadian made, called Muse S, that goes as far as measuring brain waves. That is actually considered the clinical standard method of determining whether or not somebody is asleep or whether you're in deep sleep or shallow sleep, etc. So likely, if it's able to gather that kind of data, it's going to perform a little bit better in predicting or analyzing your sleep. And so I think there's always a trade-off of accessibility of the technology versus complexity of the technology and how much information you're able to get and how accurate it's going to be. And so I would say, like, for people who are interested in your sleep, having something is probably better than nothing. Meaning that if you want to just download an app, you'll have to probably just be mindful that it's not going to give you the most accurate information, but it's going to be the most accessible technology that you don't have to pay a few $100s for. So I'm always happy to give more information, but we have limited time, so feel free to email me and find me from the UBC website.
Great, thank you. And I think we have a question in the audience.
A wonderful panel. Thank you so much. My question relates to education. Like, we know people are going to use this, whether we want them to or not. So how can we enable the public when they are doing health-seeking questions and getting all these like generative AI things, making very sensible comments that sound like, yeah, that sounds reasonable, but it's entirely wrong. So how's our role of becoming an educator to enable the public to use these technologies meaningfully and safely?
I'd love to answer that one. Yeah, it kills me when I watch television, Elon Musk or whatever talking about is AI good or bad or what take jobs away. They don't even define what technology they're talking about or what application, and the general public wouldn't have a clue. So I think that the education, both for the professionals in health informatics and other areas, is critical and not always at the level of how does the thing work, even at a cursory level. And for the public, knowing a little bit more so it's not this mysterious entity. And that, I think, was the problem when I referred to back in the 80s when we went to this expectations and the dive down. There was so much hype about AI, and I really like getting those hype cycles if you haven't seen it. And I think part of it was the oversell and the lack of understanding. So the public needs to know maybe not how it works, but a little bit more about it. And professionals in all the fields need to know a little bit about like what a rule-based system is, what a neural net is, that type of thing. So that's what we're really striving to do in our school. I'll pass to Elizabeth because we have some labs we're working on.
So, well, one of the things that we've started to do is we're looking at different types of micro credentials. We already have some in the school, and in addition to our undergraduate and graduate programs. So we're also looking at creating micro credentials that are specific to the industry, as well as individuals who want to learn more about the use of AI and its implementation and the design of systems in the context of healthcare, which is, I think, is a unique area in of itself because of the complexities of healthcare, the urgency of healthcare needs, and also because of the fact that there's a huge different value set around ethics and what we do and don't do around our patients or even our public. So really important from that perspective. I also wanted to make a comment in that there are pathways actually that have already been created in many ways. One of the things that I was involved in around information technology competencies for healthcare professionals a few years ago was I got to participate in national level conversations with the Association of Faculties of Medicine, the Association of Faculties of Pharmacy, and the Canadian Nursing Association. Glinda Reese is here, and she was part of that process. So one of the things we recognize is that the first step we need to do specifically with healthcare professionals is we need to identify what competencies they need to have as users of the technology. then we have to have these educational organizations identify those competencies and then talk to the people who are actually teaching about how they might integrate that into their coursework and to provide supports, because a lot of times educators may not have these competencies themselves. So one of the things, for example, that we did as part of our work with the Canadian Nursing Association, Glinda and I, is we were peer leaders in the province for helping academics who are teaching nurses to embed those competencies in their curriculum and how to go about teaching those competencies. And this is a fundamental thing that we all need to do, partially because first of all, I'd like to have my health professional understand how the AI is functioning, when it's working, when it's not working, when I have to be cautious and understand that it has limitations. But there's also the other piece too, is all of our healthcare professionals touch on patients. And when a patient comes to you in the office or in the hospital and they've brought some new tech in, you want to be able to have a good conversation with them about the quality of the technology, the quality of the algorithms, and whether or not what other things they need to consider in their decision making around what they're going to purchase to use and to interface with you, because that's going to be collecting data and supporting decision making for them. So there are pathways, there are ways of doing this. It's critical that we do this in the next couple of years. I think it's possible we've done it in the past, so we can take advantage of that into the future. Those pathways.
Okay. Yeah.
So I'll go back to just from a deployment perspective. I will say all of the conversations that we've been having, I was just last week, had the opportunity to be with for Canada Health Infoway, the leaders conference. We saw a lot of great demos and POCs. Everybody talked about how do we educate, how to use this. So I think we're aware of it. And I think that's the concern with the balancing act with deploying these tools out at the same time, making sure people understand, the power of the tool and how to use it effectively. So I think that's part of it. But I think what we also need to do is, and this is what we have done. I know the OCIO, for example, the government's kind of tech agency, has put out some pretty basic standards to say, use it, but be thoughtful. Kind of, I'm going to say, like I said to my kids, use your brains, when you're looking at it. And we're adopting very similar ones at PHSA that are going to do the exact same thing, because we can't stop people from using it, but we need them to kind of feel a bit of, and understand the importance of them being active and viewing the information they receive. I've also been having quite a lot of conversations with our community specialists, so with the doctors at BC, and a lot of the doctors just want to see how it works. So I think that's another good sign, is not ready for it into maybe their practices yet, but they want to test it out. They want to be active because they can see the value. So I think the balancing the education, which is critical, but also getting people to understand it and test it out and work it together, I think we'll hopefully find that balance.
Michael, do you have any pilots going on that you can tell us about right now?
Yeah, there's quite a few. I'll talk about these guys did a neat little pilot here. If I can just talk about that. We have a provincial longitudinal viewer, and I know some of us people are here for, it's called Care Connect. And there's, well, how do I say it? There's a screen about transcribe reports, and we've heard the complaints about the listing, because it literally just says, so for a physician, you get, a grid of saying transcribe report, report, transcribe report. And then they have to kind of peck through to get all that information. And one of the things that AI does very well is summarizing a document and providing that summary. So what we've been doing is looking at training a model to take that information and create a summary. Like, what does it look like? So if it's about speeding up physicians' time. I could go on. We got lots, but I don't know if people are interested in that. Maybe the other one that I think is kind of the neatest, because there is a standard, a pan-Canadian standard. It's called the patient summary, and it is exactly what it sounds like. It's a summary of your patient information. And we in British Columbia actually have a uniqueness of having a lot of great provincial repositories. It's actually not all the other provinces have this. It's pretty awesome. Like, we have a pharmacy, we have a labs, we have, demographics, etc. And what we are looking at doing is creating the best, using AI to kind of, I'm going to say, troll the data to build the right patient summary, but in context of the provider that needs it. So a cardiologist may not be as interested in all your allergies as an, or an oncologist may want something very different than an oncologist. So how do we generate and do those? So those are two of the ones that are out there. I've got more if we've got time, I can go through, but those are the ones. Yep.
Okay, thanks. And we have a question online and then we'll come. But the question online is for Lyndia. So speaking of the future, what are your feelings on the pace of change? For example, it feels like we may have whole new capabilities this time next year, which presents its own opportunities and challenges.
Yeah, absolutely. Great question. So I think one of the challenges here is that the rest of the world may be changing faster than what we're able to implement in healthcare. Meaning that an average high school student now is able to use ChatGPT to interact with AI and know a lot about AI. But it took us a while to start implementing more digital methods in healthcare. And so because of how careful we need to be, I think it's very hard for us to catch up with the rest of the world in terms of how fast these technologies are developing and how fast the rest of the world is changing in terms of AI. And so I think that's a challenge and also an opportunity at the same time, because I think with the technology development in a lot of other domains, maybe one thing that we can think about is how we can leverage things that are already developed for other applications in healthcare, such that things can happen much faster. So say, for example, ChatGPT or these large language models, they're just chatbots, right? So it's just about language comprehension and being able to converse in a natural way as opposed to coding. And so it can be used for any application, really. But if that's going to help benefit patients by introducing another way for them to talk to a healthcare provider by allowing that AI agent to provide some information, then that's one way we can leverage the fast developing technology and really, no matter where it's being developed, use it in healthcare such that we can implement things much faster. But at the same time, we still need to be very, very careful in healthcare because the consequences can be a lot more severe than some of the consumer technologies have. And so I would say there are a lot of challenges and opportunities here at the same time, given the fast-paced development of AI technology.
Thank you. And question here? For anyone in particular? Or?
I think it could be directed to anyone because I wanted to reflect on the last panel on equity and building equitable products. And so that impacts both the technology development space that Lyndia works in, but also the deployment and the evaluation and the methods that Elizabeth and Andre and Michael are faced with. So my question really is about, I think maybe I'll direct this to the three of you, is what systems are being put into place in BC to ensure that as you're deploying and developing these technologies, you're ensuring trust and it's being done in an equitable way?
I guess I'm going to start. I can certainly talk to or speak to what's happening in the academic setting. So one of the things that we're doing is we're actually doing a lot of testing. We've had several labs built out in the last little while. We have a smart home lab. We have a physician clinic lab. And we also have a digital hospital lab that's connected to like a command and control center or visualization lab. And so what we're doing is we're doing a lot of research and testing in and around using these systems and how they might be integrated into a typical environment. And part of that is also building out specific use cases and considerations for differing types of users, both patient or consumer and also clinicians. So that way we can take into account varying different individuals and their competencies and their knowledge.
I like the answers he just gave about testing, because AI to me is another technology, just like we've had other ones, and it depends how rigorously you test it. How do you test it? How many use cases not? So if you're developing something, AI, we have developed a framework where we test systems at 3 levels. One is an individual user using it with the system alone. And we've done that with the EHR decision support. And then we optimize it. Then we test the system at the level of how it's used in the clinic. That's a workflow level. And then we can look at how it works with different populations, and then look at other more global levels like organizational, testing it within organizational policy. So unlike like any other system, I think it depends on the extent of the testing, and proper user testing would include testing with user groups that are representative of users, and doing some user modeling about who would use it. So all those techniques I just mentioned aren't specific to AI, but I hardly see them applied very much in it. It's almost like AI is some special thing, but it's really another technology where all the principles of software engineering and requirements gathering apply. And I think we can look to models from other areas in software engineering.
We have another question here, but I have something to say about this. If we want to make sure that we have unintended outcomes and equitable results and stuff, we need to continue to restrict access for research. Researchers need access to all the data for whole populations, or we're going to ensure that we're going to have some very unpleasant outcomes. So I just.
And that's a problem, because often we have a really hard time getting data that's closed down by organizations and that, and BC and that. We can get more data from the US, for example.
Yeah, for example, I know my researchers are going to the US and elsewhere to get data, and that is outrageous. Yeah. And you have a question?
I do.
Can we get him a mic? Right here.
I'm a patient partner. I'm on a co-lead on a committee with Hira and Tina and Ben, trying to look at standards for virtual health delivery for the province of British Columbia. It's PHSA, Office of Virtual Health. And one of the things that we have found is that language access is huge. If we're going to deliver virtual health, never mind AI, 30% of the population of BC, I think that's the right number, does not have English as a first language. Even people who can function in English, if you get into medical talk, then they need trained translators, interpreters, and so two things. One is any talk about how AI can aid this, and whether some kind of augmented translation services might actually work. And another issue is the imbalance of power between the patient and the clinician. And is there any AI application, any thoughts about that, with another layer of potentially power imbalancing system on top of that?
So we're not POCing this yet, and I don't want to talk about, but I happen to have an opportunity to go down to some of our big cloud providers and kind of big, I would say, AI guys with a lot of cloud compute power, and they actually showed a demo of translation, because we are looking at, we have with Office of Virtual Health, we are setting up a kind of a provincial virtual health system, but we also have, your nurse line 811, and then they have those transfer. It was it was amazing, real-time translation into 100 different languages that was occurring. And not only that, this was what was scary, is they can record natural voices, and those voices then speak it out. And so you see that technology. Whether translation's good, I don't know. I don't speak all those languages, but you can just start seeing some of the opportunities that are happening. I liked your question around the empowering of patients with this. I think one of the things we do see, and this is maybe back to the question on training and getting people up to speed, is when we get all this information. So, I talked this morning about getting all your information. Okay, what does it mean? And I think that's where if we can make sure that we're all understanding how it's inferring the information, how it's summarizing it for you, it can start helping you understand your information. When you get those diagnoses, what does it actually mean? In context, this was different than in the past. You get it, it says out of range. It could be looking at other factors and saying, in this, all of these factors together, this may be the possible reason for this. Doctor probably says a disclaimer, but those are definitely the things you are starting to see occur and happen.
It's exciting. Oh, question here. Okay, this is the last question.
Okay, I'll be brief.
Make it good.
I will. So you happened upon this whole idea of like explainable AI. So how important is that, especially because we do not want to introduce any more inequities in our system? So could you speak to that more?
Yeah. Okay. Me. All right, Tibor. Thanks. I think it is really important for us. I myself personally, I don't like to see a lot of magic in a system. So I think what we need to do is understand. Obviously, this is going to produce outcomes that we're going to go. That's interesting. But I want to know, how was the data pulled in? What was the data used? What was it? Because when we do find something wrong, if we're completely blind to how that got there, I don't know how you fix it. Right. So I think that's stuff that we have to look at as we're building these machines, as we're building the models, as the stuff, Wade was working on. You start seeing little hallucinations because the data set was too small. Okay. So then how did it get there? We have to be able to trace it back to fix it. It could be a problem with the data. It wasn't trained with the right data or enough of this type of data. And so I think that's really important for us to trust it. Otherwise, I think it becomes a black box, and then it becomes that Skynet, the fear that you hear from, the people that are really scared about AI, right? Is that we don't understand how it's getting there.
Just one comment on that. I did a piece on recurrent issues. Before with rule-based AI, explainability was an issue, and showing what rules fire explained to users and that how it made the decision. Fast forward to today, and you have a lot of this running again, as I mentioned, off of neural nets, deep learning systems, and they're not amenable to showing what they did. So that's now become another research area, and the issue never went away of system explainability. How do you visualize it? How do you visualize activation patterns of a million nodes? We go to conferences where they're doing that as research topic nowadays.
Thank you. So that was the last question. There was a question online about guidelines and standards and stuff. There is a guidance on my website. It's Research Privacy, PHSA, and a bunch of us worked on it. A whole bunch of things are named there. So for that person online who asked that question, you can go to my website and you'll see the guidance there.
Thank you so much, Holly, and to our panelists. I think this is a conversation we could probably sit a whole day and enjoy. Thank you very much.